Welcome to Variations 4, a gastrointestinal unit. We're going to cover questions 13 to 17 in this video. And 13 to 17 covers the topics of appendectomies or appendicitis, a little overview of rectal cancer, some surgeries, and stomas. So for 13, let's talk a bit about appendicitis and some related issues. Looking at map 9. So how's it caused, appendicitis? Really, you've got a couple of potentials offered forth by Lewis. You've got this one here. You've also got hypergrowth of lymphoid tissue here. Either way, you start to get these signs and symptoms of appendicitis. This triangle here. Ideally, you're going to the circle pretty quick here. The circle being remove the appendix, appendectomy. We see lots of appendectomies in the general surgery ward. People usually don't stay more than a night. They get the surgery done, they stay one night for monitoring, and they're gone the next morning. It's usually a fairly uncomplicated surgery. All right, if we are a little late on getting the surgery, too late, of course, you can get that perforation. The appendix can perforate altogether, and then you end up with peritonitis, which can lead to shock and death. In any case, either anaphylactically, prophylactically, or as a reaction to perforation, we'll have some IV antibiotics running. If it does perforate, they'll have to go to surgery and get the abdomen basically cleaned out, what's called a lavage, to get rid of all the debris, and then they'll be on a heavy course of antibiotics following. That's about it. I mean, these symptoms here of the guarding and the Rovsing sign, this is something the ER physician will be doing. By the time they get to you on the wards, this will be old news. They'll have been diagnosed with appendicitis or have had the appendectomy already, and will be doing post-op care. Of course, there's imaging involved in diagnosis as well. Ultrasound, CTs, or X-rays. Okay, so the next question, not a lot to discuss with appendectomies, to be honest with you. It's one of the fairly straightforward surgeries we deal with. 14, colorectal cancer, which tests are recommended for people over 50? This is a moving target. Really, it's constantly changing, but some general ideas, some general guidelines we can find here on map 10. Just go to the top of that one. I mean, here it is. Sorry, where did that go? Sorry, guys. I seem to have misplaced that portion. I thought it was here. Oh, here it is. You got that test there every couple of years. If you have a higher risk in your family, then you can get scoped. Again, my experience with this really, I mean, age 50 is kind of that kind of magic number where you start taking these tests, whether it's the occult blood test, the sigmoidoscopies, colonoscopies, fecal immunochemical test every 2 years, all these types of things. I've known people who have cancer in the family. They start getting some of these tests done at age 45. So, I mean, and then I know some physicians who really are very conservative with things, really reluctant to do a whole bunch if the patient doesn't have cancer in the family. So it's a bit of a moving target. These are some general ideas. And again, the time to really, all things being equal, the time to really start thinking about these is around the age of 50. But if you have a high-risk family, then you need to have a discussion with your doctor and maybe start some of the stuff earlier, like I know some people have done. So that's all I really want to say with that. I mean, you can probably Google this online and get even more up-to-date stuff than what your textbook's offering you. So let's go to the next part of that question, because there's not a whole lot to talk about with what we just said. The next part of that question was, what is the eventual optimal goal of a hemicolectomy? Well, first of all, what is a hemicolectomy? Do we have that in the notes here? So just looking at this image here, a hemicolectomy is when a portion of the colon is removed. So maybe this could be because of cancer, for example, very common cause for getting, common reason for getting a hemicolectomy is cancer. So you've got cancer in this portion of the bowel, they cut this part of the bowel out. But that being said, I mean, you could have some kind of ulcerative colitis that has been, plaguing you all your life in that portion of the bowel. That is quite a viable and quite common cause for hemicolectomy as well. So they cut away a portion of the bowel. And then the second part of the question we're just looking at said, what is the eventual goal? If possible, and many times it is, the eventual goal is to do what's called anastomosis. So back up a second here. When this bowel is cut out, they're going to end up with a stoma. And it'll be part of the, if you're cutting away this part of the bowel, then what you're left with is kind of the end part of the intestine here that used to be there will be the part that's sticking out as a stoma. So you're probably looking at an ileostomy. Over time, the goal, hopefully, is to reverse the ileostomy, bring the small intestine back, the end of the small intestine back inside the abdomen, and rejoin the small intestine with the remaining colon. That procedure of joining these two parts together is called anastomosis. So we could say the ideal goal of a hemicolectomy is eventual anastomosis. Now that could take months. Some patients wait years to get the anastomosis done. It's a surgery in and of itself. For example, you'll have some patients that come in because they're getting a hemicolectomy and maybe they're getting chemotherapy as well. And obviously they're there for the cancer. But then you might see some patients who are just coming in and their diagnosis surgical wise is anastomosis, reversal of stoma. So these are the patients that are just coming in for that procedure to get the anastomosis. Sometimes the surgeon decides to do anastomosis on the spot. Sometimes what they'll do is they'll cut out a portion of the bowel, in this case, the colon, the hemicolectomy, and they'll just take the small intestine and join it right away in that initial surgery for immediate anastomosis. The patient comes out of surgery and does not have a stoma because they've had anastomosis. What drives the decision of the physician to do that? My discussions with surgeons have been is basically one thing. The big thing is the degree of inflammation on these edges. If the inflammation is too profound, it may not be possible to do it. Or not do it now. They might have to wait a few months or whatever. And so they get it done later. Whether we're doing the anastomosis at the time of surgery or later on, there are certain risks with it. It's called the big risk. And the reason you see some patients coming back to hospital from more surgery is the diagnosis of anastomotic leak. So for whatever reason, bowel contents are leaking out of this site of anastomosis, and that's obviously a huge risk for infection, peritonitis, shock, yada, yada, yada. Probably starts out as pain, excruciating pain in the abdomen from the infectious process, but, and all kinds of other feelings of lightheadedness and blah, blah, blah. But it comes with its own risks is the point. So we've covered what a hemicolectomy is. By the way, the bowel might be taken from this side or the cancer might be over here. And so they do a hemicolectomy on this side. And in that case, the patient would have a colostomy. So just in carrying on, we'll cover question 15 as well here. But just wanted to say that in addition to what I just said about hemicolectomies, there's a little more detail in the maps. Like what's a right hemicolectomy? Well, these are the portions that are removed. Cecum, ascending colon, and transverse, part of the transverse. In short, a left hemicolectomy involves the removal of the left transverse colon and the colon basically all the way down to the upper portion of the rectum. So these all have a pretty good chance of anastomosis. Um, Obviously, you'd expect with the left hemicolectomy to have a colostomy. I'll just say right out front, don't assume anything when you see your patients. Some surgeons prefer to have an ileostomy, no matter what kind of hemicolectomy they're performing. The next question, which was question, what is it, 14, I believe, or 15, asks you to look at this grid. This grid's not exhaustive. It's a quick overview. What kind of, just before we go there, let's answer some of these questions right now. What kind of output do you expect from an ileostomy? Think about where the ileostomy is in terms of the intestine. Think about, the ileum. Think about where water is absorbed in the bowels. So what kind of output once things start running? It takes a couple days, takes 2 to 3 days for the stoma to start really producing output. But once it does, what would you expect from an ileostomy? Well, because it's before the large intestine, there's a large water content there. You're at a risk for lights and fluid loss with ileostomies. Colostomy is obviously more formed. And now I think we can look at this grid here, a quick overview. I'm not going to read through every part of it. That's going to be your job. But just looking at bringing up some things. These top few surgeries here are gynae and a vascular surgery, Tupper's, which we'll talk about later. The reason why those are on the list is because these are really common things to find in the general surgery ward as well. But that's not what this unit's focusing on. This unit's focusing on these surgeries. So we talked a bit about hemicolectomies. Here's a general definition and the goals right here. So this is the surgery names for bowel surgeries and the parts that are removed and the kind of goals in terms of anastomosis. This is the one that's worth talking about, APR, abdominal perineal resection. So you have to keep in mind on something like this, where are the incisions? Where are the incisions going to be found? In 2 places, these ones. And there's a lot of, if you think of what's removed, basically if you read through that and think about it for a second, imagine that you're ending up with a permanent colostomy here. There's no other way around that. Watch out for this one, total proctocolectomies. You can see what it involves. But there are really 2 vastly different kind of trajectories with that. Just simply the total or the total with the pouch. So if it's just a total, then you're ending up with obviously a permanent ileo. 2 dressings to look at because of what's being closed up as well. But in this one, your eventual goal is to join what is left. So that would be, the ileum, that end part of the small intestine, to this pouch that's being made up. And it will take a while for it to start working again, but it provides an alternative to having an ostomy for the rest of their life. And the Hartmans, we see that sometimes too. Okay, getting down to the nitty gritty here, getting down to the end. What are the characteristics of a post-op stoma? This is really important to keep in mind. This grid here that came from an edition of your Lewis textbook. Here's the healthy color. Not so healthy, and you can read the reasons why. Not so healthy. So we're hoping to see this. Edema is quite mild to moderate normal for a couple of months, and it'll start to get better. It starts to get better throughout that time. Moderate to severe edema is not a good thing. It's not expected. A small amount of bleeding is expected, not a large amount. You can read through that more carefully on your own. Last question. I think we've kind of answered that one already. What can we expect from the output? It's going to be, like I said earlier, it's going to be a few days before we notice anything. Why is it going to be a few days before we notice anything? I'll give you a hint. We've discussed it in this unit already. Why will it be a few days before things start moving, whether it's an ileo or whether it is a colostomy? Paralytic ileus is the answer. The bowel is in shock. It's going to take a while for things to start working. But within a few days, we'll start to see some liquid output, depending on what they're taking for diet, if they're taking anything at that point. So typically, the old school way is to say NPO until bowel sounds return. So they should not take anything orally until bowel sounds return. So, I mean, you're always assessing the abdomen. You're asking the patient if they've noticed any passing of gas. How would they know they've passed gas? Especially with some of these GI surgeries. Where are we coming from with that? Their bag will have filled up with gas. It's just that simple. Their ostomy bag will have filled up with gas. Have they passed gas? Have they passed any stool yet? Do they have bowel sounds? Is it distended? Etc. So things are changing a little bit, although the rule I want you to keep in mind is that you really should be cautious, check your orders, consult with your team before, orders and pathways, because there's still a lot of the whole notion, hey, go easy on the PO intake until we get bowel sounds returned. And there's some schools of thoughts that are starting to emerge more and more saying, actually, we should start some fluids, start some sips to stimulate peristalsis. So on the whole, that's not a nursing decision, but that's something we have to be alert to and check our orders and consult with people about. So in short, you may have NPO until bowel sounds return as an order. Although it's not typically written like that, it'll just be written as NPO. You may have start on the clear fluid diet, and you may say to yourself, but there's no bowel sound. Okay, fine, then consult with the surgeon, and they'll likely will say, yeah, but we want to try and encourage them to start. So with paralytic ileus, these are all viable. If the patient can't tolerate it, they can't tolerate it. They vomit, okay, back off. Stop giving them the PO intake. Get an NG tube in, all this kind of thing. But again, it's not a nursing decision. I want to be really clear about that. You have to be really careful. Follow your orders and don't be afraid to consult with your surgeon, but it's not a unilateral nursing decision. You can read through this paragraph on your own time. It will kind of highlight some of these things in a little more detail.